Okay. This gentleman is a 54-year-old gentleman, a chronic smoker, hypertensive in the last 5 years. He's been having chest pain radiating to the left arm since the last 4 months, which used to be initially an exertion, and the last month or so he's been having it at rest. He presented to a government hospital with chest pain and was diagnosed as an anterior wall myocardial infarction. He was thrombolized. The ECG has settled on quite well. The R waves are preserved in all the anterior leads. He has small Q waves in the anteroseptal leads. The echo shows a normal size LV cavity with regional wall motion abnormalities limited to the anteroseptal and the anterolateral wall. The oral ejection fraction is about 40%. Clinically, he is hemodynamically stable with a pulse rate of about 77 per minute. BP was about 130 when he came into the cath lab. Intraoperative now it's about 170 to 180 systolic. And otherwise, there's no evidence of cardiac failure or left ventricular failure. We'll proceed to show you what the angiogram shows. The right coronary artery is normal, and this is what the left coronary system looks like.
Can you show the live?
Okay, we see it very nicely, Dr. Mathew. Thank you for the presentation. So go ahead.
Great, Manish. Manish, I'm sure you are able to appreciate the left main appears to be normal.
Yeah.
And it virtually trifurcates into an LAD, early diagonal, ramus intermedius, and a circumflex.
Correct. We see that.
The circumflex is subtotal, filling distally through collaterals. The ramus has some osteal disease, not critical, but at least 50–60%. And LAD has a couple of narrowings, 80–90%. This is what we see, and diagonal also appears to be diseased. Next picture. Previous picture. I want you to show the audience the importance of the multiple views to delineate the lesion and profile it properly. It appears that the diagonal also arises from the left main. But if you go to the next view, epicranial, you see a different picture altogether.
Yeah.
And that appears that the diagonal origin is little distal. But when you go to the LA caudal, you realize that is a fallacy which we saw in the epicranial.
Right.
And the diagonal is virtually originating close to the ostium itself.
Correct. We see that, yeah.
So we have, first of all, we have to decide what all are the disease we are going to treat. And I would appreciate your opinion, what all you would like to treat.
Yeah, so I think, again, this is a classic case of a thrombolyzed anterior wall myocardial infarction in a smoker who's non-diabetic with multivessel disease. Clearly he has targets for surgery, but has chosen otherwise to have multivessel PCI. I think the key thing is for him at the age of, in his 50s, is to do the most complete revascularization possible with current generation DES and treat his LAD, treat that intermediate diagonal and the circumflex, and in what manner and fashion you do it is irrelevant, but clearly the culprit is the LAD diagonal system, which should be tackled. And then the circumflex seems like there's a channel and could be stented as well without compromising the ramus or the left main. So that's what I would do. And let's see what your plans are.
My only concern is if you look at this view, the circumflex has disease starting from the ostium.
Yes, it does.
If I stent from the ostium, I'm definitely going to compromise the ramus.
That is correct.
If we compromise the ramus which is at the ostium, our access becomes an issue because the stent, proximal most stent, will be right at the junction.
That's correct. So there
The
are,
reaccess
yes,
will be an issue. So if we think that we may have to treat it, it is better that we go prepared to treat it from the start.
correct. I think that this is, although not a left main, it's a left main equivalent, and that's how you're rationalizing it, and that's appropriate. And so having the appropriate guide support and ability to manipulate all three vessels in a fashion simultaneously is important.
Okay, so rather than complicating everything together, I have decided to tackle two vessels at a time. So the priority moves on to the LED diagonal.
Okay?
So next. So I'm trying to get a wire into the LED, but the wire kept on going into the diagonal. So what I did is I disengaged, I just recorded this to show you. I disengaged the guiding catheter, allowed it to float in the sinus. That will change the direction of the wire. You saw that wire direction changing?
Yeah.
And I managed without changing the tip, because I don't want a long a tip for the LED, because distally the wire has to traverse to multiple septals and diagonals, which will make it difficult.
Okay. Nice technique, yes.
Okay, next. I have used that guide wire to do a rough measurement of the lesion length. So it is 30 plus, the lesion has to be more than 30. Next. I got a wire into the diagonal as well as the LED is all set. Okay, I have taken a 2 millimeter mosaic. Go ahead. Go ahead.
So I see that you're dilating into the diagonal. The lower limb of that you're going to leave alone, is that right?
Yeah, that is too small.
Save.
Go ahead.
So this is a 2.0 non-compliant mosaic?
Yeah, this is a 2 non-compliant mosaic.
Yeah, and so the question is, how high are you dilating, Dr. Mathew?
How?
What's the atmospheres and pressure that you're doing? 12 atmospheres?
14 atmospheres.
14 atmospheres, okay.
We
Thank
went
you.
up to
Atmosphere. So the balloon goes up to about 2.16 millimeters.
Okay.
now the question is whether we should plan for a crossover technique, or we should stent the diagonal first and do a crush. What is your feeling?
So, I wasn't sure what the ostium of that diag looked like in your LAO-caudal, but that would be what helps me decide whether I would do a crush or not. I would like to keep it simple because, as you suggested, it comes straight back very close to the origin of the LAD. So, my thought is I would leave the diagonal stent out of the LAD and stent the body of the diagonal, but not bring it back too close to compromise the LAD. But that's my thought. Again, it's hard to know without
Okay,
imaging.
Yeah, let us look at it again on the LA caudal, scene plus.
Yeah, that's going to be stented. There's a dissection in the diag, but that's from predilatation. You expect that.
So what I would do is I would totally agree with you. This view, what you are seeing is the pre-dilatation lesion. The ostium of the diagonal appears to be free of disease.
Yes.
So I'll spare that diagonal ostium.
Yeah, I would
And
stent
stent
the
straight
diagonal
away that
first,
the
and
body of
then treat the LAD.
That's correct. That's right. So that's what I intend to do. Give me
2 mm.
2.25 into 20, 23, 24.
Why don't you go upstairs?
Yeah. Keep the other balloon negative.
So here you'll put a 2.5 biomime by
Show the complaints.
29, 24,
Yes, Manish, 24.
24, okay. And then what I might actually do is have a balloon in the LAD just so that I get as much of the diag as I possibly can without compromising the
Okay.
prox LAD. It sounds like you're using a 7 French
That's a-
guide.
Yeah, that's a very, very reasonable thought. Okay, give the 2 mm balloon. In case any compromise,
more
at
netted up,
least
please.
we have a access wide open and we.
Yeah, I
we
think
should
that's the
not
key
have any
point,
problem.
that often it's not carinal, it's not plaque shift, but carinal shift, but still you don't want to lose access to your LAD, and so having an uninflated balloon parked in that LAD that's diseased is probably safe, especially when you have that ability.
I mean, you sound exactly like what we see these days people forget.
Yes, correct. And again, the image, the
Because
view,
ma-
the LAO caudal here is extremely important. You see how Dr. Mathew has gone extremely caudal, extremely LAO. You know that this is a perfect view because you see the tracheal bifurcation behind in the image. And these are all very subtle things that Dr. Mathew does without thinking, but are important when you're operating.
See, all the old school of thought, people like you and me learned the hard way when these stents were not available.
So I actually think
So we start thinking far ahead of what could happen, and that is the right way to do.
I would go in a little bit with the stent, but again, it's hard to know.
Yeah, I'll do that, but now there is a go ahead with the hand dilatation of the LED, because there is a compromise of the flow in the LED. I don't like it. Go ahead.
So this is another technique, it's sort of a blocking balloon technique,
Right.
which is to
Okay.
dilate and then pull back, and when you hit resistance, deploy.
I have another interpreter.
It's another method.
Does?
It's nice. That's a nice spot there.
Okay. Small. There's a biomime 2.25 into 24.
Yeah, it'll look very nice once you deploy it.
Okay, good.
Come back a bit. Little bit.
Okay, good. Good.
8, 9.
Negative. Good.
So here you're making sure that when you deploy your stent and pass it past the diag, it's going to go through. If there's any struts, you want to move that out of the way. And now he's taking out the stent balloon.
Get me a 2.5 into 37.
Very interesting. It's almost like a dual ramus, although it's a diag ramus.
I didn't follow you, Manish.
No, I said the way it appears in your LAO caudal, it looks like almost two ramus vessels, but one is ramus and one is a diagonal.
Yeah. Both too close.
Yeah, exactly. I think that biomime looks very nice, just needs to be post-dilated.
Okay. Any comments from the audience? Or?
Yeah, the panel. So, Dr. Samari? Yeah.
Post-dilatation of the diagonal before stenting the
Yeah.
LADs.
Yeah, that's what I think. I think that the placement was exact, but to post-dilate it now, before you jail it, is the right thing to do.
Okay. Give me a 2.5 mosaic shot.
And that's what he's going to do.
Two.
So he's putting a 225 stent in to make sure there's no outflow dissections. He's going to expand that first diagonal stent with a 2.5 non-compliant mosaic. We have both mosaics in the United States, both compliant and non-compliant, and it's what we like about it is not only the different lengths, which I love, the long lengths, but also very deliverable and very reshapeable, especially in our CTO cases.
Does it make a difference, the technique of post-dilatation, like how high pressure, how the ratio to the stent size, is doing it 3 times instead of 1 time?
A good question. So I think that technique varies in every lab. What we like to do is go 1-to-1 or slightly bigger and go at high pressure. And by that I mean by 16 to 18 as a minimum. depending on what it looks like inside the vessel, and making sure you stay within the stent. And that's sometimes the issue, is that if you go outside the stent, that's when you have edge injuries that you don't realize. I will usually, he's taking a short stent, I will make sure that I hit all lengths, but the main issue is that midpoint, which is not expanded, where the dissection was. You need to make sure you take your time and go up. You might have to go up twice, but as long as you get expansion, it's key.
I generally don't believe in multiple dilatation. I don't think it makes any difference unless you go on higher pressures. When you deliver a stent, you can go to the optimal pressure and deliver it. And as Manish said, slightly higher pressure, 14, 15 or minimum, and go up to 18 is fair. That's what I generally do. And always at least 1-to-1 size. Okay, I've kept the balloon there. I'm not
Stent?
changing anything. I'll see if I can deliver the stent. Sometimes if the stent strut, you can be very sure it doesn't protrude. If it protrudes, the stent will not move forward. If so, I will compress the ostium of the diagonal slightly with another balloon and then deliver the stent. Let us see how it goes.
The other nice thing about this technique is what you can do if you have some trouble advancing the stent is use this balloon as an anchor. So expand the diagonal balloon as an anchor so that your guide will not back out and your stent will go forward. But here, he's making it look easy. Very nice. So deeply seating the guide, manipulating the guide, getting the stent down. Nice long biomime stent.
Come back a little.
Yeah, come back a marker or two.
Test. Test.
Get the diagonal balloon also down, sir.
Are you happy with the position or you want it a little more out?
My thought is from here, I think you need to come back with the LAD one marker. And I would just post dilate the diag stent first. That's perfect right there. It's very nice.
Test. Test. Test.
So again,
The stent placement in relation to the marker
yeah,
is a very important issue which we tend to forget.
yeah,
All the Abbott stents are on the marker, whereas the Boston stents are 1 millimeter away from the marker. So positioning becomes a major issue
Yeah, I think the biomime is right
when we
inside
do
the
not
marker.
know that.
Yeah,
Right, yeah.
I think that is pretty good.
Protruding a little bit.
Little bit inside the left main.
Just. Okay, this way.
Go.
You saw I have kept the diagonal balloon out.
So this is interesting. You're trapping the diagonal balloon.
Yeah, negative. Okay. Go with the diagonal balloon. Right.
क्या होता है? Give him some perinom, please. Post dilate the diagonal.
Picture. Epicranial. That's okay.
So the LED itself looks fine. You'll probably have to post-dilate the ostium, especially since you've
Yeah.
dilated the diagonal balloon.
Absolutely. Give me a 3 non-compliant mosaic.
But it's looking very nice, Dr. Mathew.
Thank you.
Any other thoughts from the panel? And interesting that he had a trapped balloon and expanded that. And it's something I've seen some operators do. He's going to have to go back and
Because
expand
here
the-
why I did that is because the diagonal is just bang from the ostium.
Yeah, yeah,
So it's
I
almost
don't
like a
want
V
that
stand.
yeah.
to be
Yeah, it's like a
common.
V-stand.
So I think you
Yeah.
would have to post-dilate the diagonal a little bit in the midsection.
Keep this.
And
Yeah.
then
negative.
perhaps at the new carina that is created, maybe a kissing balloon, high inflation, high pressures there.
Yeah, I think
We
that's
did
right.
that.
So the question here, Dr. Mathew, is will you finish with a kissing balloon inflation or not?
If I had used an IVIS, I would have decided easily. But here, my priority moves towards the LED.
Mm-hmm.
So I would post-dilate the LED properly, and that would be my priority.
Okay.
Is he okay?
Test. Okay. This is a 3 mm mosaic, gone up to 15, 16, negative. Go up.
So full expansion of
Same.
the stent, no issues at all,
Negative.
no dog boning. So you're going to get a very nice result.
Chest pain.
Take a picture.
Looking good.
Epicorder.
see the importance of post-dilatation here with the ectatic segments. And go up there again.
So I'll go up there again at the ostium.
Yeah, that needs to be expanded.
Yeah.
There you go. There was a waist.
Looks okay.
Looks quite good.
Go up, 80. One more dilatation. Okay.
And of course, your patient is doing very well, no issues, no hemodynamic.
Yeah, no issue.
You've saved the ramus looks very good. You still have access to the circumflex.
But ramus, don't you think it looks a little more pinched?
Yeah, it does. Again, that's sort of the nature of the
Give me
beast.
another guiding.
It's probably more carinal shift because of the stent. And
Yeah.
that's the thing that we have to keep reminding ourselves is not to chase disease that may not be significant physiologically.
No, 6.10.
Give me another 7. Sheath also. Now, when we are going to treat, there is a possibility we may need another stent for the ramus also. If that is so, what would be our strategy? We'll need simultaneously 3 stents.
Yeah, I mean, I would try to avoid that at all cost here. But if it's necessary, I would. You've already stented the LAD, and I would treat both the ramus and circ in a sort of a V fashion.
Okay.
But my attention would be to give nitro, fix the circumflex, and do everything I could not to stent the ostium of the ramus.
Is it the technical issue or?
Well, it's carinal shift. It's the fact that you have a strut of the LAD across of it, probably. It didn't look severely diseased when you first took your pictures.
Yeah. So what I'm doing is I have already have an access open on the left. So if by any chance I need a stent for the ramus also, so having 3 stents, 3 balloons in one guiding catheter is a little cumbersome. So what I'm doing is I'm going to work from the left for the circumflex and give me a C on blue wire.
The other thing you can do, which I often do, is use an 8 French guide system, although still 3 stents in 8 French is tough. 3 balloons in 8 French is not a problem. But this is another technique, the dual guides. We use dual guides for often for CTOs. Clearly, even sometimes in the left system when we're doing retrograde. CTO, PCI have the circumflex for the LAD. But this is another.
I agree, Manish, but only thing is when we have 3 balloons, 3 wires, while positioning the balloons and stent, when you pull or push, the other catheter keeps moving up and down. So that is a little discomfort for me. Here,
so these are the first guide was a 7 French, and then this is a 6 French, or you have 2 7s now?
2 7.
2 7s, okay.
I somehow like sevens.
Yeah, so do I. So where's this wire going?
I am trying to get it into the circ.
You'll need a bigger bend.
I need a bigger bend. Okay, LA quarter.
So you're doing very well. We have about 15 minutes for transmission. Yeah, there you go.
Okay, AP.
So this is a Xi'an blue.
Give
It's
me
a
the 2 mm
beautiful
blue.
wire for these types
Yeah.
of cases. Extremely safe, and you saw Dr. Mathew made
2 mm balloon.
that look easy, but the equipment has gotten so much better.
Give me another BMW wire. And a draw sheet. Give me the wire.
Yeah.
Cyan blue is a lovely wire, but the problem, if we got it as a default guide wire, with the CTO guide wires are the best are Asahi, then your lab, all your lab is Asahi lab.
Yeah, no, I agree.
So
I
there's
think-
no
I
much
think-
difference with BMW or
Yeah,
other
yeah.
guide wire.
I think that this has a little bit slightly different feel. I used the BMW Universal. You know, this is a steel core wire versus the other one being a nitinol wire. This is a Universal going into the Ramus.
I'm trying to.
Okay, so you have 4 wires in that one guide.
It will be a small test. Tend to be more difficult.
Very nice.
Okay. Draw sheet. Okay.
Certainly the key thing in these cases with multiple wires like this is to make sure your ACT is well above 300 on heparin, and to make sure that all your guides are flushed every time equipment comes in and out, so that thrombus is not introduced or air is not introduced.
That when you raise that point, it's very important. Then when we have multiple catheters in the same guide, there is a chance of air getting sucked in and producing issues which we may not realize till things go wrong. Test. Go up.
What size mosaic is this? 2.5?
The same 2 millimeter which I use for the diagonal.
Okay, 2.0. Good.
Picture. Okay, give me a 2.25 into another 24. Or a 2 also is fine. 224 is fine.
It's a big circumflex, Dr. Mathew, with 3 branches.
Yeah, that's right.
And I think you're doing a masterful job of revascularizing this young man.
I mean, your point which you raised in the beginning of the case, when you are introducing the case of believing in total revascularization, do a complete job, especially in a young man like this, is extremely, extremely important for the long term for this particular patient. Hold on. I need the same balloon, one the other. What I'm doing is I am putting the same balloon into the ramus
Yes.
and keeping that access open.
Yes, that's exactly what I would do. It's a beautiful strategy, and that 2O mosaic is getting its work.
That's right. And it's quite nice about this balloon is, even though we have used it multiple times, the profile is being maintained.
Yes, that's correct.
We have used it in 3 vessels. This is the 4th vessel it's going in. But I have no compromise on the profile.
So again, this is going to be a 2O biomime by 24 or 225 by 24 that goes in the circumflex. And your plan is to nail the ostium of the circumflex in an LAO caudal view.
This is the way. Okay. Give me the stent, please. I need a 3 mm post-dilatation balloon, what we had taken earlier.
Give me one more deflator.
One more inflator.
So are you going to place a balloon in the LAD as well, Dr. Mathew, or no?
I would like to keep it because I don't want any compromise on the LAD.
Okay, so he's going to have access to the LAD while he deploys this circ stent, and also has access to his ramus with a wire and a balloon.
What anticoagulation is using?
Dr. Mathew, I assume you're using unfractionated heparin?
Yeah.
And again, paying meticulous attention to ACT. For heparin, we're using ACTs every 30 minutes. Again, the biomime...
See, even though that it's almost a 90-degree turn and a small vessel and bend distally, this tracking of the stent is quite surprisingly good.
Yeah, wonderful. Yeah, absolutely.
Okay. Give me the balloon. It's here only, no? No, I have it.
You want another one?
Ah.
So now he's going to put a balloon parked in the LAD from the other guide.
Yeah, that's right. It is parked.
Then they're going to go to an LAO caudal and deploy the stent. And
Go to LA caudal, please. Okay. Go up. On the stent.
So, beautiful demonstration. He's not jailing the distal circumflex. He's got both other branches secure. He's making sure the origin of the circumflex is covered by stent. And he has control of all vessels.
Next.
Again, very elegant two-guide technique. I think if I would have probably done it with an 8 French and 1 guide, but his points are extremely valid and valuable.
There is a little pinching, so I'll do a,
Kiss.
a kiss.
Yeah.
First dilate the ramus.
And I think while you're there, you might as well dilate the LAD and do all 3 as a simultaneous.
We'll do that. There is some pinching for me to put a. What do you want? You want a stent there or no stent?
No stent.
All of you agree? Okay, go up. All balloons up. Okay, next.
Beautiful. Stable patient. Short inflations.
40%.
40%.
I noticed in the proximal LAD stent, do you see something?
What you see is
At
the
the-
overriding diagonal underneath it with the haziness,
Yeah,
and that's the diagonal, it's not the LED.
okay.
And there's also a small dissection in the ramus. So Dr. Mathew, you might have your wish of stenting the ramus now. But it's
Yeah, there is some compromise. Give me a 2 point, give me a 212 or 230.
Okay, Dr. Mathew, this is looking, I'm in awe. I love it. This is looking good. You have about 2-3 minutes of transmission time.
Yeah, give me one extra minute.
Oh, you got it.
Okay.
So what's your plan?
I'll have a short stent in the ramus and one more post dilatation, and that's it.
Wonderful. Okay. So again, the downside about doing kissing balloons, which I think, or blocking balloon and then a kissing balloon, is that you can interrupt the side branch, and that's the price you have to pay. If you have a dissection, you have to stent. But I think the key thing is being ready, as Dr. Mathew has completely thought through this entire case well in advance of anything that could happen. He has bailout ready, and that's the only thing that's important in these cases. Everything else you'll execute just fine. There you go. Okay, this is going to be. So he's trying to get his LED balloon down. There it goes. He's manipulating both guides as he needs to,
Okay.
and at the same time not closing off the left main. And you could see, because of the stent outline, beautifully where the ostium is.
Okay, go ahead. Go ahead with the stent.
So I think they often refer to this as a ping pong technique, with bouncing the
Yeah,
catheters in and out
Yeah.
to get sequential
Yeah,
balloons in.
yeah. I mean, this is one technique also for perforations, ping pong technique for
Go up.
retrograde left-to-left CTOs. And
LED then.
Dr. Mathew is showing this as a beautiful, it's almost it's a quadrification. There you go. Look at that. Love it. Masterful work. Masterful work. Beautiful demonstration, lots of teaching. We can't thank you enough, Dr. Mathew. Let's take one last picture and see. Very nice. Very nice.
Thank you, Manish. Thank you. I should thank all the panelists, faculty, and all the people who are attending the session. I hope I have answered all your questions and try to do as best I can.
You absolutely demonstrated a very tough case, made it easy, and walked us through it. Thank you very much. Have a great morning. Thanks for your staff. Thank you.
Let me have my one more minute.
Yeah.
My cath lab staff. Can you focus on them, please?
We see them.
Fo-
Go ahead and introduce
Yeah,
them all.
Ajit and I have been working for last 2.5 decades, and I've got Pandey, our chief technician, Christy, and all our other staff, of course the anesthesia group, and it's tremendous working in this institution because they are all superb technicians on their own.
Thank you very much. Congratulations to your team. Thank you, Dr. Mathew.